it has transformed healthcare delivery is undisputable.
We are using now digital health tools to improve access to care and also to improve health outcomes. So we don't see it as a complete replacement, these virtual visits where you're seeing a doctor from a distance. We see it as a clinical blended model. So during the pandemic, for example, when all offices were shut down, we could still see our patients virtually. This technology is really doing some amazing things in terms of improving access to care.
Power of telemedicine lies in its ability to unite medical expertise and patient care, irrespective of distances, is also included. By connecting healthcare professionals with patients through advanced technology, we're not only saving lives, but transforming the way healthcare is delivered.
Telemedicine has shown that it can really provide for, at the very least, a more convenient patient experience, right? And so I think what we need to do is to find ways to allow for this to be effected at scale, right? So it may look like having many of these clinics that are distributed across Jamaica, across the Caribbean, tapped into a telemedicine service. The Western Regional Health Authority has, I believe, 80 clinics, or somewhere in that order of magnitude. And so imagine if each of these clinics was a hub for telemedicine. I know Ram will have interesting thoughts on that, but imagine if each of these clinics was a hub for telehealth. What it means is that you'd be able to deliver healthcare services at scale to an already distributed network of individuals who need it most.
But we always look at the quadruple aim. We're looking at 4 benefits: better care and outcomes, lower cost, better patient and clinician experience, and better quality of life.
That better quality of life that can be delivered through telemedicine is threatened by the very disparities to healthcare raised by Dr. Michelle Griffith, the president of ISfTeH, the International Society for Telemedicine and eHealth. In the organization's 25-year history, she is the first woman to be president and has over 30 years of experience as a clinical and administrative physician specializing in internal medicine. You're prompted to ask her, the event host, why Jamaica was chosen for the organization's first ever digital health event in the Caribbean, Telehealth, Caribbean Connected, August 18 to 20, 2023, at the Iberostar Rose Hall Beach Resort. The event, sponsored by Cable and Wireless Business, Catalyst Health Innovation Forum, 19 Labs, and Tech for Life.
We chose Jamaica as the country to start with, first in the Caribbean region, because there are a number of local leaders and stakeholders who are doing some really innovative things in the field of digital health. Additionally, Jamaica just released the first of its kind standards for the practice of telemedicine, so we felt that this would be the ideal place to have the first conference bringing awareness to digital health in this region.
Standard bearer for digital health in Jamaica, Professor Winston Davidson, CD, Chairman and CEO of Telemedicine Limited, is the leading applied researcher in the development and practice of telemedicine in Jamaica and the Caribbean through the development of an innovative technology platform, Doctor on Call, the culmination of 25 years of research and development in the region. He also chaired the committee that created the first standards for the practice of telemedicine in the Caribbean and Latin America. As validation for Dr. Griffith's rationale on why Jamaica, he's ready to share this quick word with us.
As a young and developing country, we were the first movers.
Jamaica's standards, readily standing up to scrutiny.
Every test, user acceptance test that was done, my colleagues did it freely with me when we were asked. Because I was head of a school of public health, I could do some of those tests too. And so therefore the rigor of the system was impeccable.
Validated by the Caribbean, these standards were gazetted.
After the launch of the standard, the government then gazetted the standards. And so internationally, everything is approved by the WTO TBT. And so this here is part of the Gazette. Once it's gazetted, it's now part of the WTO documentation.
The story of his platform, Doctor on Call.
Doctor on Call is not only related to doctors, it's related to every single health professional that has a counsel. All have signed on to these standards because they were part and parcel of that group of technical persons who participated in the process.
Having chosen Jamaica, we're on call for other particular stories of interest. Let's start with Dr. Bradley Edwards, the acting CEO and senior medical officer of the Maypen Hospital in the parish of Clarendon. Of concern, here is the island's health record.
1 in 3 Jamaicans are hypertensive, and of those, 4 out of 10 of them were unaware. Approximately 50% of Jamaicans are overweight at the moment, and it's probably a little more now. Tamu? Probably a little more now. 1 in 8 Jamaicans are diabetic, almost half of them are unaware, and 3 out of 20 Jamaicans have chronic kidney disease. At least 8 out of 10 Jamaicans are inactive.
Senior medical officer of the Maypen Hospital for 23 years, you'd be quite interested in his perspective on healthcare delivery in the rural areas.
I also have a private general practice office in a place called Moko in Clarendon, right? And the farmers would come there, I'd look at them and say, "Sir, you're sick. You have to go to the hospital. At least go to the accident and emergency department." No, that they just can't manage that because 1, then there's going to be an extremely long wait to get to see anybody. 2, they have the animals to go pick up, and there's nobody else to take care of the animals but them. So they have this dilemma: do I go to the hospital or do I go to my animals? And you can't force them. They usually make the decision to go look after the animals, you know, and you have to really convince them. Now, if we had a system that they could be seen without having to go and wait in this long line, which is inevitable once you go to the hospital, then they would be absolutely appreciative. So I think telehealth is a good solution for this particular population.
Professor Minova Thame is Dean of the Faculty of Medical Sciences, the University of the West Indies, Mona, and is the first woman to hold this position. Professor of Perinatal and Pediatric Medicine and a consultant pediatrician, she is involved in active clinical neonatology, administration, and research. Her research involves the roles of maternal anthropometry and body composition on fetal growth in pregnant women with sickle cell disease. It also highlights pregnant adolescents, comparing them to mature pregnant women. Following her presentation, addressing a question on obesity and pregnancies.
So we've actually done work on obesity in pregnancy, looking at a population both at university and at Victoria Jubilee. And as you know, there are levels of obesity. So you have type 1, 2, and 3. And when we looked at our population, our majority of our women are actually falling in type 1 and type 2. And when you look at the outcome of those babies, they're not, or those pregnancies, is not as bad when you compare it to the normal BMI women. Where you really see the problem is with the type 3, the morbidly obese. But we don't have a lot of morbidly obese women going through pregnancy in Jamaica. So you're not seeing what you'd see in North America, right? But the type 1s and 2s, yes, they're obese, they will have other problems, but we don't see a lot of mortality and morbidity from obesity per se in Jamaica.
Well, you might want to ask,
the adolescent does not gain as much weight during pregnancy as the adult.
No. So what I'm saying is the adolescents actually put on more weight as a compensatory mechanism to try and grow a better baby. But in terms of their usage of glucose, no, you won't be able to look and to see. But having done the studies, we know that the pregnancies are very different.
So they put on more weight.
They put on more weight, and that is what puts them at risk. Because at the end of the pregnancy, usually you should shed, okay? One of the things that help you to shed is breastfeeding. Mm-hmm. And in Jamaica, we know our initiation rates are quite high, 98%. But check them at 6 weeks, we're down to less than 50%. For all reasons they give why they can't breastfeed and they don't want to breastfeed, unfortunately. So they don't lose that weight as rapidly. And what we have seen, as I said, is that they retain the fat mass, the bad weight, in a sense, not the lean. And therefore, it puts them at risk because that teenager may have 2, 3, 4 kids. And each time she keeps retaining, you put her at risk of obesity. So it's something that she should be conscious about, something that we should advocate for and make sure that they know so they can do things about that obesity, because it's preventable.
Meet Roger Graham, chair of the Healthcare Disparities and Digital Health HDDH Working Group of ISfTeH, the group presenting the Telehealth Caribbean Connected event. He is the man responsible for leading the strategic vision of West Indies Radiology Outsourcing Limited, with specific focus on enabling a culture of clinical excellence, customer centrism, and technologically innovative operations, expanding the company from Jamaica to delivering services across the Caribbean. Seated beside him is colleague ISfTeH Thomas, head of the company's IT department. West Indies Radiology Outsourcing Limited, getting started, overcoming challenges.
During emergency services, when you can't get a radiologist to come out, what do you do? And through that, people started to get more used to the idea of teleradiology, and that's kind of how we started. We also had issues in terms of multiple PACs, multiple risk solutions. So each hospital has their own systems. And what we had to have doctors doing is jumping from multiple systems in order to report, which is not efficient or effective, and it hurts your turnaround time, which is key for most hospitals and most doctors. So what we were able to do is do integrations so that studies can seamlessly go between their systems and our systems. And all of these are HIPAA compliant, and ISfTeH can kind of speak to that. And for some locations, as I said, that have internet issues, we've had to develop solutions where we can compress the data to ensure that the data can move more quickly through low bandwidth.
As Roger indicated, we have various setups. Setup that we use all depends on the client that we're servicing, right? So just speaking to our setup, it has 3 main components that are normally involved, and how they're involved, again, depends on the customer that we go to. So we just go through, put up all of them. So the first thing is that we have our system, as Roger indicated, is cloud-based. There's an API that allows for integration. So you might go to a customer that already has a RIS and a PACS, and they say we want to integrate. You might go to another customer that says, I don't have anything, which is fine. We can just have internet, and then they can route the studies to the cloud for us. So we set up based on what they have, and then additionally, we also put in what you call a gateway. So the gateway now, the main reason for the gateway is to encrypt the images before they go to the cloud. So what would happen is we'd have their local modality, sending the image to a machine that has a DICOM viewer that it can view, and before it goes into the cloud, it passes through this gateway that encrypts the images, so that if anybody were to try anything, they wouldn't be able to because of its encryption. And thirdly, of course, you would need the DICOM viewer to be able to view the images as they come from the modality.
Addressing a particular requirement of the Jamaica Data Protection Act.
As part of the Jamaica Data Protection Act, they require that you have a data protection officer. We will appoint a data protection officer that will be specifically required to ensure that our policies and procedures are maintained around the Jamaica Data Protection Act specifically.
There is a buzz with the news that the country is seriously moving to create a strong foundation for a digital health ecosystem where a sustainable electronic health record (EHR) platform is being designed and implemented that will invariably strengthen the island's telemedicine capacity. Welcome to the Information System for Health Jamaica ISfTeH, and you're all ears, being guided by the Ministry of Health and Wellness representatives, Dr. Hilary Hines, Clinical User Experience Designer, and Dr. Kin Thu Ka Ong, Clinical Informatician.
When it comes to the framework under which all these initiatives operate, it's a Pan-American health organization framework called Information Systems for Health. Now, I'm going to just shorten it to ISfTeH, and it's covered under Component 2 of the HSSP program, and it deals with improvement of management, quality, and efficiency of health services. Now, within this framework, ISfTeH is seeking to support Jamaica in identifying strategies, policies, and standards for interoperable and interconnected systems, as well as best practices in health data management.
And the EHR?
It's a tool. It's essentially an input tool at this time. And in order to deal with data management, you need to input data properly. So it's a key foundation for information system for health.
Dr. Hines.
Yes.
Your background is in user experience and ensuring that clinicians are able to do what they need to do in a user-friendly way. How will the system be rolled out the same way in each facility? Will it be customized to each? Because every hospital is different, every clinic is different. How will the experience be for the users?
Okay, thanks for that question. So really and truly, user experience design, just in case not everyone might be aware of it, it's really about driving innovation and solution through empathy. And empathy here is not simply just connecting in a very one-shot way. It's actually a process and a discipline that we go through and that we repeat, and we never really stop it. So it's iterative. So as the facility grows and evolves and changes, we evolve and change with it. So as you said, every facility is different, every health center, every hospital. So System 1, while there are things that are standardized across the entire health center, like we know there's a certain way that, for example, nurses will record information. There's a certain way that doctors may record information or interact with patients. We can actually customize it based on their workflow.
Sponsor Cable and Wireless has been a pillar of support for the development of telemedicine over the years. Carol Robertson, Director of Sales, Government Enterprise and IT Solutions, points to the future.
We're seeing a future that includes smart cities, which is another area that Jamaica got the approval in my organization to be the first smart city location in the Caribbean. Nobody else has gotten approval for smart cities under the Cable and Wireless banner. All right, so clap, Cable and Wireless, woman. So we're enabling smart cities, education, security, coming with some stuff for you guys for security. We're gonna create a more secure Jamaica.
The event banner, as podium backdrop, promotes an impactful theme. Setting up telemedicine has never been easier. It's reliable, innovative, and affordable. Theme reflecting key points of interest from respective presentations.
The traditional footprint is you go get a grant or you do something for your project that's a sunk cost to get the telemedicine off the ground. But if we add the efficiency angle of the data management to the physical components, we don't become in telehealth a cost center anymore. We become we stop revenue leakage and we improve labor and we have ROI to show it. That's a different way to present telehealth to government leaders or to private health systems that are always looking at the telehealth as an outlay of cost. We're presenting it as, we're going to make your operation more efficient and potentially let you see more patients, which they understand that, the value of that.
My first introduction to telemedicine was when I went to Dominican Republic and we launched a telehealth platform with Project Hope in DR. And that work itself was to support moms that were affected by the Zika virus. And so these are impoverished moms really trying to make sure that their children are supported throughout their pregnancy. And so how do you use technology in that rural area? We kind of went with a localized approach. We let the nurses kind of led the way, and then had American physicians as well, alongside contributing that knowledge gap. But as in regard to eHealth itself, it was developed to improve cultural competency in delivering culturally competent care. And what does culturally competent care means? It means that physicians that take the time to understand your uniqueness and your needs, and the fact that you're not being dismissed because of your ethnic background or differences of where you're from or your income. So they really take the time to actually go deeper.
What our work includes is to start with disaster trainings, with community organizations, so using technology to arrange these kind of trainings, preparing community-based health providers especially, providing them the trainings to how they can provide care in these kind of disaster situations, and also how health facilities are prepared to provide the services. Installing telemedicine kits in the communities, both at the health facilities and with the community-based health workers, and connecting them with the disaster response teams that have been established by the government. And these are the kind of slums that we are working in Nairobi and around.
As we had continued to go, we start integrating different remote monitoring tools. One of those remote monitoring tools is an ultrasound. So now, imagine you have a wife, and you guys have gotten pregnant, and you guys are living in a remote area, and it takes you 10 minutes or 20 minutes or 30 minutes or an hour to get to the hospital. Now, what it allows you now to do, because of the ultrasound, is to be at home and be able to do a scan of the patient's belly and share that imaging with an OB-GYN in real time. And that OB-GYN is able to tell you the child's fetal heart rate and movements and the amniotic fluid of that child as well. And so that is really encouraging people that are living in rural areas to have another tool of safety and reassurance for that your baby is actually doing okay.
This is the value proposition today. It's efficiency that's integrating use cases into the treatment of the patient. So there's our original mission, which was improve access, improve equity to specialists. We know how to do that now, all the way down to the phone, but use medical devices and connect them now to the EHR and improve the process so that clinicians can spend more time with our moms and dads and patients instead of doing administrative tasks.
You could digitize all these delivered remarks on a platform that keeps querying all that's needed to make telemedicine work in a global setting.
It's the community worker that more than anything is the key. In telemedicine, we connect between two locations. And it's a connection in which the brain is the doctor on one side, and the hands and the heart are the community worker, the 18-year-old, usually young woman who sits over there and holds the hands of the patient. And yes, you absolutely need the doctors, but if the community worker is not energized and confident, it will not happen.
Physicians and clinicians often got burned a lot, right? If you think about all the things they have lived through the last 10 years, like knew this thing. So often, even if you tell them something very easy to use, they wouldn't believe you. So the way you try, I recommend just get that initial set of clinicians, get them adopt in this, right? And show them how easy it is. In fact, when you do our trick in our EMR, right, you could create the templates in there, right? Instead of repeating all these things over and over again, create one template, just click on it, like it literally is like save you all the typing in this, right? Really easy, right? Or some of the physicians just you can add in like remote scribe or thing there, right? Again, they don't even need to do any writing. They love that, right? So there's a bunch of these, I think, tricks you could do that in the end is about when we think about our software is about you have to respect the clinician's time. Right, their time is very precious. Is there a way you could create things that save their time? If you could, they will love you.
It's good to see, and I really appreciated your focus on the importance of incorporating clinicians and the end users as you create and develop this software, because it actually goes nowhere unless you are not intentional about ensuring that we as doctors are comfortable. We call it comfortability, right? And if we're comfortable, and I will say, yes, doctors are very late when it comes to adopting technology. You know, we're at the latter part, right, of the digital revolution. So I think once you've got to invest that time on the front end in terms of making sure that physicians are comfortable with utilizing it, and then they in turn will ensure that their patients are comfortable. And it's about that doctor-patient relationship. I don't care how, all the bells and whistles of technology. Human behavior is human behavior, and we will always be human beings, and we have to understand that psychology as we are talking about how these potential solutions can really revolutionize healthcare. For the clinic boxes in the rural areas in Africa and India, what are you using for connectivity? Is satellite? Do you find a lot of connectivity issues, or what? How? Yeah.
They have 5G. It's cellular. They have 5G, and these cubicles come with air conditioning, heating. They're waterproof. They're hurricane-proof, and very durable. So it's all connected up.
Just a question. So with all of this, very interesting. Clearly, I would not be practicing medicine in the next 10 years. I wouldn't recognize it. But what happens to the human aspect of it? That sort of human touch that goes with medicine. Where does that fit into all of this?
It's a great question. For example, in the cubes, you're going to have an assistant there. There's somebody there with that patient, so they'll physically be there. It's not going to be a physician, but it's an assistant to help with the telehealth consult. That's beneficial. In the case where they're doing telehealth in the homes, just to be able to talk to somebody, it's again more beneficial than not. Right, they're all so satisfied, and especially the people in Africa, they're just so pleased to be able to get somebody online to get help.
You can't improve patient outcomes without patient stories. There's no way you can do that, because you have to understand that everybody's life, everybody's symptoms, everybody's pregnancy is different, and we cannot treat them the same. So culturally competent care is something I always advocate for.
The transformation being sought, therefore, is clearly about successful outcomes. Michael Castorino is a healthcare business executive, bringing over 30 years' experience in corporate strategy and development, technology innovation, and healthcare system board governance. His stewardship, as that of others, is one of achievements.
It was a large health system. The CEO wanted to standardize the relationship, wanted to prioritize service lines, define best practice, and develop business plans by service line. And he created a big C-suite and clinician team to monitor this. And basically, we went out to 20 sites. We provided telestroke, mental health, ICU, specialty services to the emergency room, and then the physicians. And the accomplishments that we made were improved market share by interventions, patient population, and collaborations with other hospitals. The cost savings were basically through the appropriate utilization of care and ED throughput and capacity increases and reduced length of stays. And actually the mortality decreased. And when you put a value of all that for that year that over these 20 sites, it was $67 million that it provided in value. And we extrapolated that throughout the system, and in 1 year, the value that it provided was $600 million. Yeah.
We're on target to reduce skin cancer deaths in Ireland. Skin cancer is the most common cancer in Ireland, and we have about 1,500 people die of skin cancer every year, but by using digital dermatology, we think we can get that down to 150, and we're on track to do that.
Telehealth basically will grow revenue. It extends the service area. It captures patient leakage, and it is a great way to manage bundle payments for big populations. And hospitals can sell services to other hospitals with their specialists, and they can increase their net patient revenue. And telehealth also contains costs where patients would stay local with their support. There's clinical efficiency and the right care in the right location at the right time, and the cost per case goes down. And it improves patient satisfaction, the improved outcomes.
Question and answer sessions are about shared perspectives. This one between Professor Martin Curley and Professor Winston Davidson also provides insight on improved outcomes.
What I'd like to ask you, based on the presentation, there seems to be the discovery of a universal formula for the development of synergies. What I see here is a synergistic effect, but that synergistic effect is based on a relationship.
First, it's about strategy, synergy, and synthesis. So we have a simple strategy, and if we synergize and we get synthesis and we create a platform, ideally there's a lot of innovation going on around the world. It's all fantastic, but it's not aligned. But we could have a common platform. That platform would withstand great forces, but it would allow this massively parallel innovation to happen, and so many advances, life-saving and life-extending advances to happen. Then you're absolutely right. Things are all connected, and one of the things we look at in New York is the idea of One Health, and that's going to be critically important. But you yourself mentioned yesterday, Professor, the enterprise aspect. So there's a health economy. So we can improve health, but we can also grow the health exports from Jamaica or from Ireland. But we can also have sustainability impacts. Like in the UK, the NHS is the biggest single contributor to the sustainability issue. Hospitals are the single biggest contributor to plastics consumption. So for example, one innovation that's being introduced by Dr. Roisin Malloy is a non-contact infrared thermometer. And there's no plastic with that. Nurses can read the temperature 5 times faster. It's actually 10% more accurate.
Improving outcomes are about changing mindsets, and the development of electronic health records in Jamaica is about achieving this change.
Not everybody is used to change.
Agreed.
How will you transition, or what's the strategy to kind of transition persons who are used to paper, used to, this is the way that we do it, this is the way we've been doing it, works. How do you make that experience less stressful?
Understood. And that's an excellent question, because empathizing again with our partners instead of just end users, basically they're dealing with the rigors of their day job, the rigors of their actual goals, which is to give care to their fellow Jamaican citizens. And with that, we don't want to add too much of a burden as it relates to that transition process from paper to an electronic health record. Some people might even be nervous about, okay, like I'm not used to typing so fast, or there's a particular way that I'm used to writing, so I can think about how I'm treating my patient as I'm writing. How can I get that same experience on a computer or on a device? And what we've done is that really we like to test a lot. So we'll build something and then we'll test it. So we'll have persons in real life situations, they'll like see a patient or simulate seeing a patient, and they'll actually go through the process of entering information, documenting, and viewing information and getting to certain conclusions. And we ask them, how did you feel about this? Like, were there any blockers for you? Were there any pain points for you? And from there, we'll take those suggestions back, and then we can iterate and continue to test. And we'll actually continue to do this even through our go live, which is when we actually have everything going process. And we're constantly going to be creating this, what I like to call feedback management system, where we get this feedback, and then we know this is a process of how to act on this feedback. And that's how we manage to really want to manage that change. So it's a long process, and it's a very rewarding one because we really get to see people smile and get excited about when they actually see their needs being met.
Professor Curley's perspective on the impact globally of the adoption of electronic health records in Jamaica.
I think Jamaica could be a lighthouse for the rest of the world in terms of the fast adoption, and what we learned today in terms of the adoption of the electronic health record. It's going to be very exciting. Thank you.
We are ready to go, ready to work, ready to work.